and spark some ideas around maybe some approaches, some strategies, some lessons that you're going to hear about from these three panelists that you actually can bring back into your work, into your communities. So I'm not going to go over full bios. Those were in the website announcement. So to learn a little bit more about each speaker, please go back and reference the webinar announcement that was sent out. But the way that we'll go today, first we will kick it off with Jamie Almanza, who's the Executive Director of Bay Area Community Services. After about 15 minutes, she will pass the baton to Dustin Harper, VP of Strategic Partnerships for Institute on Aging. And then he will pass the baton to Dr. Bamberger, Assistant Clinical Professor, University of California, San Francisco. And at the end of the presentation, as Monique said, we'll take Q&A. So with that, welcome everyone. Thank you, panelists, for your time and your work and your openness to sharing what you're doing in the field. And Jamie, I'll turn it to you.
Great. Thank you, Lori, and good morning, afternoon to everyone. My name is Jamie Almanza. I'm the Executive Director of Bay Area Community Services. We are a social benefit corporation in Oakland, California, and we provide an array of services for homeless individuals, individuals struggling with behavioral health challenges, as well as specific aging-related services. The programs that I'm going to feature today are wrapped up in our Housing Fast Support Network, and we opened a continuum of homeless services to serve Alameda County 3 years ago. And I'm going to talk about the evolution of those services as we progress. So the models that we are using in our homeless services are premised on a housing first philosophy and model. We use an evidence-based practice named critical time intervention that is basically a stage-based model to help people exit from homeless to housing. We are a firm believer, as are our panelists today, that housing is a prescription for health, and that housing and secure and safe housing must be achieved first so that you can work on the other life stressors. Another big component of our model is that we are radical about finding flexible funds from government and philanthropy to help us purchase all of the things that are needed to secure housing and successfully have housing for our participants. So what we did 3 years ago, we took over a program that is in a single residence occupancy style motel in Oakland, California. And in Oakland, just like in many other parts of the country, the homeless rate for single adult individuals has grown. Our last homeless count has grown by 25%. And we designed a model called Housing First that really takes traditional HUD, Housing and Urban Development funds, that we used to get for transitional housing, which usually had a duration of stay of 18 to 24 months. And we truncated that length of stay to something around 4 to 6 months for individuals. We started by targeting encampments and moving in encampments, either in a whole encampment or in a mini encampment, as well as for individuals who are chronically homeless. And we moved them in, and during the 4 to 6 month stay, we are only focused on moving them out into permanent housing. It's the first model of its kind where we're actually leveraging traditional transitional housing dollars, but using it in a rapid rehousing, interim housing with only one goal, which is permanent housing. So the focus on this, of course, has been high impact. We took a program that was serving just 50 individuals a year, and now we serve over 400 individuals a year. And it looks like from a slide, am I having technical difficulties? Oh, sorry. Okay, Thank you. So for types of housing, like I said, within this model, we have our interim housing program as well as we have a medical respite program. And I'm going to focus today on the medical respite program. I just want to check in to make sure that the slides are working.
Yeah, it looks like they're working. It was taken off slideshow, so I can put it back on real quick.
Thank you.
No problem.
Great. So we are going to focus on medical respite, and that's the model that I'm going to be diving in a little deeper here. So overarching, one of the things that the community asks about is whether our program is housing. And we actually say that it's not housing, even though that's counterintuitive because people are moving in and living with us for a short duration of stay. Our focus is all about rapid rehousing and locating permanent housing for individuals who have been chronically homeless for many years. The other beauty of the model we use is that once we locate permanent housing, we are able to use the last phase of critical time intervention to make sure that the housing sticks. And so an opportunity for a landlord who may have not gotten their first rental payment from our client, they can call us and we can use those flex funds to pay that rent until we can help the person develop their own skills to pay their rent going forward. And I'm just trying to advance my slide here. Monique, if you want to take over and just advance the slides, I'm having trouble. Thank you. I wanted to talk a little bit about the population characteristics. So you can see that predominantly the individuals we serve are African American. They're predominantly male, and they are predominantly in their 40s. This is the population that we focus on, and this is our local community demographic. Next slide. Further characteristics of the individuals we target is high utilizers of the system. Individuals who are generally on general assistance or have zero income, who are very deep in their active substance use disorder, like I said, who are male African American, who the government would otherwise deem able-bodied and so are not necessarily qualifying for Social Security disability benefits, who come straight from sleeping outdoors, and who are living with generational poverty and trauma. Next slide. So now as we move to the medical respite program, after we inducted the Housing Fast Support Network program to permanent housing, we had a community partner, a very large hospital system locally, who reached out to us and during the course of relationship building said that they were struggling with these same homeless individuals that we target and serve, but individuals who need to exit an inpatient physical health hospital stay. And so over the course of a couple months, we developed a program to meet the needs of both the community as well as this hospital partner, and we implemented a medical respite or a recuperative care program. Now, this program focuses just on exits for individuals exiting a physical inpatient stay as well as an emergency room stay. They are for individuals who are homeless and who otherwise would be recovering or recuperating on the street, but with our program design are able to come in and live with us in a medical respite model for up to a 4 to 6 week duration. The goal is to reduce recidivism for high utilizers who frequently go in and out of inpatient and ER stays because of their lack of housing stability. Next slide. So we have a very pragmatic approach to our medical respite recuperative care model. We provide, and one of the most important provisions is room and board, so that someone is able to recuperate under a roof instead of outside. We target stays for under 30 days for medical respite, and we also have a behavioral health medical respite program with targeted stays of between 3 and 10 days. The behavioral health respite program is for individuals exiting a psychiatric inpatient stay or a psychiatric emergency room stay. We also provide tailored medical meals. We provide pharmacy coordination and pickup. We provide basic nursing care. And most importantly, we provide access and support for individuals to get to their follow-up doctor's appointments. Next slide. Other benefits that we happen to provide outside of the scope are we hook people back up with their benefits. We do a lot of supportive case management. We find miraculous housing options even within a 30-day length of stay, and we linkage and brokerage to other providers so that their aftercare plan is enacted when they leave. Next slide. Just a very brief kind of overview of what kind of facility is required to implement and run a recuperative program. A single room capacity for high needs, including having separate bathrooms, is always very helpful. Accessibility design, because a lot of our people have accessibility needs. Access to laundry, separate fridges for meds, separate space for locking up their valuables. And one of the things from a program design perspective is to ensure that no tenant's rights are established during this medical respite stay. Next slide. So in our year one pilot, we started with 10 beds with this hospital partner who purchased 10 full beds. And we started with a very slow ramp up that mutually was supportive of both organizations and their needs. And we wondered whether discharge planners from hospitals would even think to refer and be top of mind for referral to this program. And sure enough, from day one, it took 13 months to use all 10 beds with an everyday capacity, which demonstrates the tremendous need for hospital discharge planners to refer and get access to medical respite beds. Next slide. Halfway through our pilot, our hospital system partner said to us, well, we also are having an extreme issue with overcrowding at SNFs. And so we opened our access for medical respite to help the hospital system alleviate the SNF backlog. And so our referral mix changed from going from 100% direct from inpatient and ER to 60% from SNF. Next slide. A little bit about partnerships, as Lori mentioned, was important to mention. Partnership and devising a partnership at the forefront of creating a new strategy to support our community is paramount to success. And one of the things that we really worked on up front is the ability to share data, and with that data to also analyze the sharing of risk and the sharing of reward. And that proved to be advantageous for both organizations. Next slide. Biggest rewards thus far, we have replicated this partnership. We've scaled it up. We've doubled it from 10 to 20 beds just over a year. We also implemented another respite program for one of our other behavioral health partners. And we've demonstrated that there's great efficiency and flexibility of intervention for this model. Next slide. Some of our biggest challenges, and this is the top one here, we are different from the medical sector. We are a community-based organization, social service, behavioral health organization, and we speak different languages. And through this partnership and pilot, we had times where we had to get on the same page just in terms of having different priorities, different philosophical orientations, and again, really capturing data and sharing data so that we knew we were helping the hospital partner with their outcomes, and in turn, our outcomes were being achieved as well. Next slide. So some actual outcomes here. We have reduced the length of stay of the average homeless inpatient bed by 400% with our medical respite program. Our access and clearing of SNF beds is unparalleled for this hospital partner, and we've had a 25% readmission reduction for psych emergency for our behavioral health partner in a 30-day duration. So you can see that this model is tremendously successful and efficient. Next slide. Some of our data, just to show you, we've served 202 patients in that first year pilot. 8 people died with us while in medical respite, and we looked at those deaths as success as well because they did not die outside as they would have without this intervention. We had a surprise outcome of 42% of individuals from this 30-day medical respite program that we were able to discharge to a stable living situation. And then you can see we've, in our behavioral health respite model, even though housing outcomes are not part of the model, we had a 21% discharge to stable living situation for our behavioral health respite program. Next slide. And this just captures your average individual that is able to access our services here in Oakland. A gentleman who's born and raised in Oakland, has 0 income, who has been homeless for 7 years, who agreed to come into our program after a relationship ended with a partner who lived in an encampment. The participant has active heroin use, alcohol use, sleeps most of the day. Participant has been denied SSI, family is estranged, and participant suffers from major depression. Participant has not seen a doctor in over 10 years and is afraid they may have an STD. Participant has 3 jail stays in the last 2 years. So this encapsulates exactly the individual that we moved from the streets to our interim housing program and to permanent housing here in Oakland. Next slide. And I am going to wrap up in interest of time and pass the baton to Dustin Harper, my colleague over here, and look forward to questions after the webinar. Thank you.
Thank you, Jamie. I appreciate that. And thank you to the folks at Root Cause Coalition for devoting some time to this issue. It's one that is of particular interest to myself and to my organization, Institute on Aging. I've been fortunate enough to spend the past 10 years working on developing and administering programs that provide community-based alternatives to nursing homes, and not surprisingly, housing is a key component of making those programs work. I think you heard a good overview there from Jamie around the value of a medical respite model, and I think one of the things you'll hear from Dr. Bamberger after me about his desire as a physician to be able to prescribe housing to his patients. I'm going to focus my time a little bit on making more of the policy and business case for investing in housing as an alternative to long-term custodial care, specifically for the Medi-Cal population. I'll talk briefly about one program in particular, the Community Care Settings Program, where we've partnered with a Medi-Cal health plan, the Health Plan of San Mateo, and a housing provider, Brilliant Corners, to provide community-based alternatives to nursing homes for nearly 200 individuals over the past 3 years. But before that, I want to spend a little time clarifying the problem that we're trying to solve, and from our perspective at least, how strange it is that we've created some of these artificial systemic barriers, particularly the restrictions that are in place around healthcare dollars being used in collaboration with housing. Monique, do I have slide control, or can you advance?
You should. Is it working?
It doesn't seem to be working, so if you could go to the next slide, that would be great. Thanks. Let me say a couple of words about Institute on Aging for those that aren't familiar with the organization. As an organization has taken this systems issue on as a high priority. We're based in San Francisco. We're a non-governmental, independent, community-based organization serving about 20,000 individuals a year throughout the Bay Area, Sacramento area. We're primarily a services organization, but we also see research and advocacy as key components of our mission. The slide here outlines some of the primary service lines at IOA. Next slide, please. Within the community living solutions bucket at Institute on Aging, we really see ourselves offering 3 types of solutions. And please forgive me for the cheesy visuals. I have 2 children under the age of 5, so I find myself trying to explain things in simplified terms sometimes. But we really think there should be a nursing home transitions program, or slide, in every market to ensure that individuals have the opportunity to return to community living and to ensure that nursing home beds are occupied by individuals who really need to be at that level of care. And we recognize that an enhanced set of services to support those community placements is necessary, and we do that in a variety of ways. And finally, to our healthcare partners in particular, we see improving patient or member flow through the post-acute care space as part of the value that is created by investing in programs like this or in areas like housing. Next slide. So let me jump into the problem a little bit as we see it. I've had the opportunity to talk with health plans, nursing facility administrators, service providers, state officials all up and down California about this issue, and there's actually pretty widespread agreement on the fundamentals of the problem. From our estimates, there are about 15,000 people in nursing home beds right now in California that, while they meet eligibility criteria for a nursing home, don't need to be at that level of care. Said another way, if there were a community-based alternative provided, we think about 15,000 people in the state could and would prefer to live in a more independent setting. And at the same time, safety net hospitals or high volume Medi-Cal hospitals, whichever term you prefer, all have some version of a daily list of individuals who don't need to be in that acute setting who they're having difficulty placing. Most of those individuals, hospitals are trying to find nursing home beds but are having difficulty because capacity is limited and because nursing home facilities are concerned about the percentage of their beds that are occupied by long-term custodial individuals. Next slide. So this seems like a significant waste of resources to us. And our project with the Health Plan San Mateo has given us more tools to estimate how much of a waste of resources this is. We put the opportunity at about $720 million across the state, without including the savings to the hospitals, because that is a more complicated component. I'll show you a couple of high-level cost-saving slides from our project with Health Plan San Mateo to give you more of a sense of why we think that. Next slide. So in 2013, when we started working with the Health Plan San Mateo to solve this problem at a county level, you can see what their annual long-term care spending was. 3 years later, it's reduced by about 40%. This is significant. Granted, this is at the county level, and we think this is replicable on more of a statewide level. Next slide. When we look at the costs at more of a per member per month level for the individuals in the program, you can see the total cost for the individuals was essentially cut in half. And of particular note to us, one of the questions we're often asked is, well, what about when you transition some of these difficult, high-risk individuals, many with behavioral health needs, back into the community? Don't they just become high utilizers of the ED and hospital? To date, within our project, the data actually shows the opposite. The per member per month cost related to healthcare for the individuals served actually is about 30% less when they're in the community than when they're in the long-term care facilities. Next slide. So to get at these results, I really would love to say it's a magical secret sauce, but it really boils down to two things. It boils down to housing and enhanced services. Next slide. But this is where things seem to get a little bit more complicated, because systemically we've made it hard to offer these two things as an alternative. Healthcare dollars are not supposed to be spent on housing unless someone is in a nursing home. So to create community-based alternatives, we have to try and cobble together funds from different resources, many of which are not easy to coordinate with the healthcare system. Next slide. To say it a little differently, in places where we've given managed care entities financial risk for long-term care, we're also not giving them the tools to manage those costs.
Dustin, are you still there?
I'm still here. Can you hear me?
Yep, I can hear you now. Is it next slide?
Yeah, next slide, please.
Okay.
To take it one step further, the financial rate setting process between the state of California and Medi-Cal managed care plans actually disincentivizes long-term care transitions. Remember I said we cut the health plan's long-term care cost by about 50% for the individuals in the program. Unfortunately, what that means in the current system is that the health plan loses about 75% of their revenue for those individuals. It's really only because the health plan of San Mateo is committed to proving this concept that they can rationalize this to their local stakeholders. So again, I emphasize all this to try and reframe the way we think about investing healthcare dollars in housing. When it's being utilized as an alternative to a long-term care facility, it's not about a handout or a moral argument necessarily. There's a clear, from our perspective, there's a clear policy business case for investing in these types of alternatives. Next slide. So I won't talk about the community care setting pilot in great detail today, but this is the program's overview flyer. It gives a little bit more of a description of who we're serving, what we're providing. I'd say of note that we're not just waiting for folks to end up as long-term care residents. We're also serving individuals that we call diversions. And the cost savings data I shared earlier includes those folks. There seems to always be concern when we talk about programs like this about whether or not we need to develop and enforce an artificial barrier that individuals have to spend a certain amount of time in a nursing home before we'll consider a community-based alternative for them. We don't think that makes any sense. It also is more of a population-based approach as opposed to where someone happens to be in the continuum of care at any one time. I would also highlight for folks that aren't working with this population that nursing homes aren't just filled with older adults. About 50% of the population we serve is under the age of 60. Traumatic accidents, physical disabilities, etc. These are individuals that often really don't want to be in a nursing home setting, given where they're at in their life. Next slide. And then I would just say a few words around the housing channels that we're using to support the project. Our housing partner, Brilliant Corners, works to develop capacity in all of these housing channels, and we have a multi-agency team that does its best to match client needs to available housing as it becomes available. Ensuring that community placements are successful is often about making sure that individuals are put in environments where they have the tools and resources around them to succeed. And certainly for some individuals, that looks like a different type of housing. And then next slide. And for Institute on Aging, in terms of things that we're looking at to try and address this at more of a statewide level, we are looking to replicate this program with other Medi-Cal health plans that currently have financial risk for long-term care, despite the financial disincentives that I talked about before between the health plans and the state. We're working with those health plans to advocate for policy changes around the restrictions around how to use Medicaid funding and the current rate setting issues. And we're also working with, we're just getting started with an organization called the Sorensen Impact Center out of the University of Utah. They're one of the prominent pay-for-success intermediaries across the country that is working on developing social impact bonds. And so we're looking at trying to do something similar with the state of California in regions of California where health plans do not have financial risk for long-term care. It's going to be a lengthy process to see if we can make traction in that area, but like I said before, we're committed to trying to change this at more of a systems level. So I'm happy to talk with other individuals offline around more specifics around the program or answer questions today. But that's a little bit of an overview of what we're up to and one of our primary points of concern. I think at this point I will hand it over to Dr. Bamberger and let him talk about housing from his perspective.
Good morning, for those of us in the West Coast, and afternoon elsewhere. I'm not sure how well my Prezi is going to work, so hold on. I'm Josh Bamberger. I'm a family physician, and for the last 25 years or so, I've been taking care of homeless adults in San Francisco. And that sort of provides me with this sort of unique perspective, perhaps, about housing as a healthcare treatment. And as a physician, I just, there's nothing I have in my black box, in my black bag, that is, that really helps homeless people accept housing. There's no study that's ever been done in the United States that shows that colonoscopies or immunizations or anything that we have really improves the health of homeless adults except housing. I'm going to give you some evidence for that and then share with you the results of a report that we recently completed with the Kresge Foundation that documents 9 communities around the country that have used healthcare dollars to expand permanent supportive housing. So really looking at expanding the amount of housing stock for homeless adults or people exiting nursing homes. So in the United States, we have a healthcare system that has clearly been getting a lot of attention, and it's really designed in a way to take care of emergencies rather than long-term health problems. So as Atul Gawande writes about in the New Yorker, the healthcare system really isn't designed to have these long-term longitudinal relationships, and we really need that to be the case because chronic illness is commonplace, and responding to a healthcare system that just deals with accidents or infectious diseases doesn't work. So what we need, as Dustin and Jamie have said, is we need a way to write a prescription for permanent supportive housing, but we have to have a system where that can be filled. So think about all the components of how you get a medication filled, and you have to replicate all those pieces to have a supportive housing system where the healthcare system can prescribe it. And if anyone wants extra credit, they can tell me who this prescription is written for back 9/22/2011. So just to give you some evidence, here's results of a study that I did in San Francisco a number of years ago, where we looked at the mortality among people who had AIDS and were homeless at the time of their AIDS diagnosis. Now, this isn't HIV infection, but actually clinical AIDS. And what we found is of the people who were not housed in permanent supportive housing, they're represented by that blue line, we found that only 25% of them were alive after 5 years. But for the people who were housed in our permanent supportive housing in San Francisco, called the Direct Access to Housing, we had a much, much lower mortality rate. And that's represented by the red line. And this is a better outcome in terms of reducing mortality than pretty much any pharmaceutical or other intervention that's more mainstream in the medical world could ever get. So that hopefully convinces you that housing is a good thing for people who are sick and at risk for death if they aren't housed. And then the other question is around cost. And here is another study that we're still in the midst of. We're in the 5th year of a randomized trial of permanent supportive housing. And these bar graphs represent people who were randomly assigned to the treatment arm, which was a permanent supportive housing facility in the Tenderloin in San Francisco called Kelly Cullen Community. And what you see is that the cost of the people who were randomly assigned to the treatment arm was about $30,000 a year in healthcare costs alone in the year prior to entering housing. And then after they were housed, it went down to about $12,000 in the first year and then down about $10,000 in the second. And then most importantly is this next set of bar graphs, which shows that the people who were randomly assigned to regular care, which could have been housing elsewhere, but in this case, it just wasn't the housing that we offered them. You see that the year after their matched controls were housed, they increased their healthcare costs pretty dramatically. And then in the second year, their costs dropped down. And the reason for that kind of baffled us at first until we dug into the data a little bit. And what we found is that people who were in the control group, which was 92 people, about half of them actually were housed elsewhere, which explains their reduction in healthcare costs. So in some ways, our study both proved our hypothesis that healthcare costs go down with housing in both the treatment arm and the control arm. And then, of course, another important component is the 18 of the 90 who were in the control group died, which makes their healthcare costs very low. And only 7 of the people who were in the treatment arm died. So that also explains reduction in costs. So it's really important to acknowledge that in this study, we were targeting the highest users of the healthcare system. And many other studies that have looked at housing as a healthcare treatment do not necessarily focus on people who are super expensive. And it's very important that we stop fighting amongst ourselves as to who deserves housing. I think everyone deserves housing. But if you want to reduce healthcare costs, you have to target the expensive people. So in the CCSP program that Dustin talked about, we know these people are super expensive because they're in the hospital and they're in the nursing home costing, $300 per day in the nursing home. So when we move them out, they're going to reduce costs. But it's very important that if you're trying to make your bar of cost reduction as your bar that you're trying to prove to the system, that you start with people who are expensive. Not necessarily the people who would, be the most beneficial, if you will, in a bigger picture, but they are the ones who reduce cost. So now I'm going to shift to a national lens, where we've completed this really fun study where I was given the opportunity to go around the country and find 9 communities where the healthcare system has invested to expand the stock of permanent supportive housing. And we recently released this report. There's a little, if you look on your slide, there's a little website that you can go to, which will give you the full download of the report, and I'll end my slides with that so you can write it down again. And I'm not going to go through the entire report, but it's, to me, a really interesting time in our country where there's so much tumult in healthcare delivery, and we're sort of fighting between people who sort of say, well, we're going to do good with the healthcare system, and people who say we want to reduce cost. But in many ways, I believe our study combines both of these. So I'm very hopeful that this report and the CCSP study, which is one of the case studies, can help to move particularly Senators Alexander and Murray, who are working hard across the aisle to find true solutions right now. And these could perhaps be a roadmap for finding a way to combine the goals of more conservative folks with the goals of people who are more progressive. So just to give some specific examples, one of the first studies we looked at was a case study that was done in, let's see, which is our first one. A case study that was done, come on, slides. In Minneapolis, I think, is the first one that comes up. And in this study, what we found is that the state made a large investment in housing bonds, as well as providing all homeless, disabled adults with a housing voucher, which was about $850 a month, which could be used in the open market to find apartments. But what was great about the healthcare system's investment is that they paid for housing navigators, similar to the Brilliant Corners folks that Dustin talked about, to try to match the needs of each homeless person with the type of housing that would most benefit from. So if the healthcare system had a very minor investment, but was sort of the enzyme that got the substrate of housing vouchers and housing bonds to move the whole equation forward. And they were able to find a way to match the right treatment to the right condition, and are now on track to end chronic homelessness in Minneapolis by the end of this calendar year. The next study that we looked at was a much bigger study, and some of you may or may not be familiar with. In California, beginning in the 60s, parents of people with developmental disabilities went to Sacramento and worked very hard to get the legislators to find a way to pay for housing for people who are exiting state hospitals, who've been adults who were born with developmental disabilities. And what they did is create a fascinating system where over 700 small houses have been purchased with state funds through regional centers, where the state provides a 20% down payment cost to purchase these houses, and then pays for the mortgage in perpetuity for people living with developmental disabilities in these places at a rate that is, 4 or 5 times the rate that we pay for rent for folks who are homeless. So this is a really interesting model that, if you can imagine a more utopian world when we exited people from asylums back in the 60s and 70s, if we had delivered a similar system for people with mental health disorders, probably none of the folks who I take care of in the Tenderloin would be on the streets today. The next case that we looked at was a more local investment, and this was in Los Angeles, where the health director in Los Angeles, Mitch Katz, who used to be my boss in San Francisco, truly believes that housing is a critical component of the healthcare delivery system. And when the county was looking at a significant increase in revenue coming from uninsured people all of a sudden receiving insurance from the federal government through the ACA expansion, and being a healthcare delivery system, he saw big revenue coming to places like Martin Luther King Hospital and LA County, and was able to advocate with the Board of Supervisors to free up the local funds that had previously been used to pay for uninsured people and have that move towards housing. So in Los Angeles, they are in the midst of the largest expansion of permanent supportive housing paid for by the healthcare system using local dollars that are freed up through ACA expansion. And through this expansion that is expected to bring 10,000 units of new housing to homeless people, is all of 0.3% of the total health department budget in Los Angeles. So it's a really small component. Some people even call it a rounding error, but for me, this rounding error is ending homelessness for 10,000 people, reducing healthcare costs, and doing what I think is what we should be doing as a healthcare system, which is improving the healthcare for people who are at greatest vulnerability. This is a picture of one of the buildings, the Star Apartments in Skid Row in Los Angeles, and that's a 100% chronically homeless building owned by Skid Row Housing Trust. And the next picture is a single room occupancy hotel that's been renovated and has about 100 units that are paid for through Brilliant Corners also, who provide a housing voucher through the health department. So that's a fantastic opportunity that I think many of the communities where you guys are coming from could replicate through this flexible housing subsidy pool. And then the next study, and I only have a few more, so hang in there, that I'm going to highlight comes from what Dustin was just talking about, which is the health plan of San Mateo, and I won't spend much more time on it because I think Dustin did a much better job than I will ever do. But this was really the only managed care organization that's paying directly for housing. It pays for residential care facility costs, and it also pays for some independent housing, and then partners with the local housing authority to prioritize new buildings that are coming on through HUD funds towards people who are the highest users of the healthcare system. One of the motivators to make this program come about was that the largest skilled nursing facility in San Mateo County was threatened to be closed sort of precipitously, and that stimulated the health plan of San Mateo to say, well, where are we going to put all these people who are in nursing homes who are going to lose their beds? And that motivated them to find an alternative that provides more autonomy and less costs, which Dustin talked about. And then the last case study that I want to highlight comes from Portland, Oregon. And in Portland, they have, they're early adopters of healthcare reform. Even before the Affordable Care Act came on, the 6 hospitals that predominantly provide Medicaid services in Portland were already involved in a accountable care organization. And get to that slide in a second. Here we go. And they were all working together to try to find alternatives to high-cost, low-impact healthcare delivery. And they first funded a medical respite through the Central City Concern. And then in September of 2016, they all put their hospital community benefit obligations together and pooled it into one $21.5 million one-time investment, which came to Central City Concern, delivering 350 units of permanent supportive housing. And this is such a great program because the investment is so large in Portland that the local government doesn't even need to provide a local operating subsidy. HUD doesn't need to provide vouchers. This is free and clear with almost no debt to produce 350 units of housing and thereby end homelessness for 350 of the highest users of the healthcare system. So that's an exciting opportunity. Here's a picture of what the building will look like, and on the ground floor is actually going to be a primary care clinic, which is providing behavioral health and primary care services for members of Central City Concern, which is the largest provider of homeless services in Portland. So I'm going to wrap up, and then we can perhaps have some questions. Let me see if I can get to my conclusion slides. Just a few more things about the community benefit obligation. This is something across the country that is a $62 billion industry. So every hospital must use some of its revenue to maintain its nonprofit status for community benefits. And in January of 2016, the IRS, of all people, said that it's okay to use community benefit obligations for housing. So this is a new opportunity, and with many of the people who were using the community benefit obligation who were uninsured, taking down that pool of money, now being insured, a lot of hospitals, to maintain their nonprofit status, has to find a more diverse way to meet their community benefit obligations. So all of you, wherever you're calling in from, can reach out to your hospitals and say, hey, yo, what are you doing with your community benefit obligations, and would you be interested in helping us to end homelessness and reduce costs? So in conclusions, robust housing can be a big intervention, but it can be a very small percentage of the healthcare dollars. So remember, the healthcare industry is about 17% of the gross domestic product of this entire country, and 0.1% of that money going towards housing would be enough to end homelessness. So we just have to find a way to align the goals that we're working towards with the healthcare delivery system, and these 9 cases give us a roadmap for doing that. It's hard, though, and people are really scared. No one really knows how the federal government's going to come down in terms of auditing. Some of these innovations might seem fantastic, but then they're going to get attention that isn't wanted, and that may shut them down. So people are very careful these days about innovation, and that's hopefully going to change a little bit now that the effort to repeal and replace ACA hopefully is at least dead for the moment. So maybe we can have more opportunities for innovation going forward. And the real goal here is just to expand the pool of funding that comes into housing. So we often fight in the affordable housing sector between who should get these limited dollars. Should it go to a family, a single mom raising 2 kids? Should they get the limited affordable housing dollars, or should it go to a chronically homeless person? And we need to stop this infighting and actually expand the pool. And the best place, I believe, to expand the amount of revenue coming into the housing pool is to come from the healthcare sector, where the healthcare sector, which is huge, can invest a small amount, reduce its exposure, and also improve care. And the best example, I believe, of that is what we have going on in Los Angeles, where they've really created a flexible housing subsidy pool where money from philanthropy can come in, where money from the local government can come in, or money from managed care can all go into one pool that can then be prioritized towards the highest users of the healthcare system, and thereby reduce homelessness, reduce costs, and improve outcomes. So I'm going to leave with this URL for our report, and I look forward to spending the next 10 minutes hearing if you guys have any questions that we can answer. And I think these three presentations really fit really nicely together and should generate some interesting questions. I'll turn it over to you, Monique.
Thank you. And I'm just going to look if we have any questions at this time. Participants, if you have any questions, go ahead and type them into the questions pane on your right side of your screen. Just a reminder that this webinar and the slide deck will be posted on the Root Cause Coalition website. So any URLs or links will be available there if you're interested in learning more information about anything that our presenters talked about today. So we have a question from Jeannie. Her question is, what is the average LOS for individual living in housing?
I think I can answer that one. So the local operating subsidy is, I believe, what you're referring to. And in San Francisco, which is obviously the highest housing market in the country, we spend about $600 per person per month for a local operating subsidy for across our 1,800 units of permanent supportive housing. Another 300 usually comes from the tenants portion, which is 50% of their income. So that gives a local operating cost of about $900 to $1,000 per person per month. And then services are on top of that, which run between $400 and $500 per person per month.
Just a follow-up, what about the length of stay for individuals in housing?
Oh, is that what that LOS was?
Yeah.
Permanent supportive housing is permanent, so there isn't really a length of stay in our program. People don't move out, so they live as long as they live.
Great. Roxanne has a question for all the panelists, I guess. Is how do you recruit and train staff to work with this challenging population?
It's a very good question. I think for us, we have adopted a model in the last 5 years of hiring people who have been formerly homeless as peer counselors or housing navigators, and that's a primary job qualification. It's not the only job qualification, and we certainly do hire people who have not had that personal experience, but I think the diverse array of experience is usually within a peer model and or a social worker model, people who have worked with homeless and in the encampments and on the streets before is preeminent to someone that maybe has never worked with the population or has just sat in an office and provided a social service.
Hi, this is Josh. I answer that very differently, and I really like the question. So I think this really goes at the real differences between the kinds of programs that I was highlighting and the program that Jamie runs, which is fantastic, and focuses really not on the highest users of the healthcare system, the people who are most mentally ill with chronic medical problems, people who are more able to get into the workforce. And in our setting, we specifically go out of our way to hire people who have advanced degrees, and we try really hard to pay them the wage that will keep them in the work, and then spend a lot of time talking about the vicarious traumatization that we expose ourselves to, and really try hard to support our staff to recognize that this is an honor to see the human condition, but can be very uncomfortable. And we have to find a way to keep people focused on why we brought to ourselves this work in the first place, and figure out a way to sort of metabolize the pain and discomfort that we are exposed to every day so we don't go home and kick our cat. It's very hard work, and across the 43 buildings that I directly supervise in San Francisco, I would say that some of them really get it right and have an incredible job retention, and others don't and have a much higher turnover rate. And it's not just the amount of money that we pay staff that keeps people there for a long time.
Yeah.
And I would echo those things, but emphasize something slightly different around particularly the transition process for individuals leaving long-term care facilities and returning back into the community. Part of what's really necessary is that there's a need for a partner in that process, someone who can get involved prior to transition and be a partner when the individual returns back to the community, because for many of these individuals, they've been institutionalized for a long period of time. We're asking them to move into a more independent setting. Sometimes that's going to be difficult. Sometimes that's going to require them to coordinate their own services, but they're going to need a partner in doing that. And that doesn't necessarily mean that the primary emphasis is around coordinating their medical care. It's providing and coordinating a lot of the non-medical components that are necessary to be successful in community living. So having someone who is able and willing and having a model to have more of an intensive face-to-face in the home partnership with someone is, we think, really essential to making that piece successful.
Great, thank you. Angelica asks if one of our panelists can potentially explain what is the establishing of tenant rights and how that plays into your program.
Oh, sure, I can say that. I mentioned that. So the interim housing program that I presented on the Housing Fast Support Network, one of the operational and legal rubs that we have in this particular model is that it's a short-term program, and yet there's rights that come along with living in transitional housing. And so our model is to really work within those rights, absolutely, and to also motivate and inspire individuals and to really set the culture of the program model that it's not permanent housing, actually. It's the means to an end to find the individual permanent housing. And so tenants' rights are usually established after 28 days living in a situation. And so that was really my reference to that, is there is just an operational challenge within this model of interim housing and the mechanism we're running it.
That's a great, I also want to comment on that. I think that, Jamie, your program is wonderful and recognizes what you're able to do. And our program is all permanent supportive housing, and we have to also live with the challenges that come with tenancy rights. So when people move into our permanent supportive housing, they have tenancy rights, and that means that moving them to a different place, even if the fit that we get up front isn't right, is very difficult and goes through an entire process that often involves the legal system. So as the Billy Joel song says, you know, you got to get it right the first time. If we place somebody in the wrong housing from the beginning, so that they don't have the adequate supports to thrive in the housing that we offer them, then our ability to move them to the right place is very limited. In a less structured system, you can have more flexibility to find the right place for somebody over time and not be hampered at times by the permanency of tenancy rights. So there are balances between these two systems, and finding the right way to work through tenancy rights, which is something that can be critical to success, versus not having tenancy rights, which can be critical to flexibility, is an interesting dichotomy.
Mm-hmm.
Awesome. This question is targeted to Jamie. Sarah asks, if the demographics helped, in your program, the demographics are individuals with substance abusers with no income, how do they maintain permanent housing after obtaining it?
Great question. So a lot of different ways. I think, you know, one of our conundrums in terms of the housing stock that's available to the individuals until we achieve what Dr. Bamberger mentioned is that we are looking for creative permanent housing options on an individualized basis. So someone with general assistance getting $336 a month who has an active substance use habit, they are generally leaving our program and going into shared housing and with our flexible funding patch. So they may be living in a room with one other individual. And, you know, our work in our critical time intervention model is to teach the skills to either manage their habit, to kind of find replacement behaviors. But the model is our staff follows them into that permanent housing situation to ensure that whatever their struggle is, whether it's lack of income and poverty, whether it's trauma, whether it's active substance use, that we're there to provide the skills development and opportunity to be that safety net until we're sure that they're able to maintain in that permanent housing situation, and then we titrate down. And that's really the beauty of the critical time intervention model. It is not easy. And I think what Dr. Bamberger also just said around, you know, different placements, we're working without vouchers or without permanent supportive housing access for the individuals I presented on. And so we're getting extremely creative. We're doing a lot of family reunification. We're doing a lot of roommate matching, and we're doing a lot of renting our own single family homes and or purchasing them, and then having individuals pay us rent. You know, I think it's a very individualized process to create success for this very difficult population.
Great, thank you so much. And it looks like we have come to the 2 o'clock Eastern hour. I just want to give a big thank you to our panelists, Jamie, Dustin, and Josh, and a very big thank you to Lori Peterson and Collaborative Consulting for partnering with the Root Cause Coalition on this webinar. Just a reminder, the webinar slides and recording will be available for download on the Root Cause Coalition website later this week. And if you have any questions for our panelists, feel free to reach out to them directly. And at this time, I'm going to end the webinar. Thank you all so much.
Thanks, Monique.